free FHIR Connectathon webinar hosted by UPMC Lab. I'm Jer Pingol, your moderator for today's session. At UP Manila Standards and Interoperability Lab, or UPMC Lab, our mission is to strengthen digital health capacity in the Philippines, driving progress towards universal health coverage. This year, our focus extends beyond our team. We are committed to empowering our broader community with valuable insights on health interoperability, artificial intelligence or AI, cybersecurity, and health data standards. Now, in preparation for our June 2025 FHIR Connectathon, we're introducing the working draft of the Philippine Core Interoperability Guide, or Core IG. This guide is key to shaping how health data is exchanged in the country using FHIR. We hope you're excited to learn, share, and connect with fellow members of our community of practice. We would also like to express our gratitude to our partners, CSIRO Australia and DFAT, for their support in this capacity building initiative. Okay, now let's dive in. Okay, to explain why this effort matters for our digital health ecosystem and how the core IG differ from the past IG work, I'd like to invite Dr. Alvin Marcelo of UPM Silab. Over to you, Doc Alvin.
Thank you, JR. Good morning, everyone. Thank you. Um, Allow me to share my slides. It is very lonely to set standards without a large community supporting the standards. So I think DOH and PhilHealth will be very well served with the community that we have in the call who will listen, test, and give feedback on the standard so that there will be confidence from our national government agencies when they release a standard that there's a community that can actually adopt and support it. So our real goal is to create more interoperable health system. And before, these were just personal and collective aspirations. But recently, the Universal Healthcare Law and the National Integrated Cancer Control Act, or NICA, laid the formal and legal groundwork and framework for digital health interoperability. So it is not anymore an optional thing. It is actually part of the law that we make sure that the health data of our patients become portable. And portability means it needs to be interoperable across the different information systems that we use in our healthcare facilities. And to achieve this interoperability, we must share a common language so that human to human, machine to machine, we know that we are talking about the same things. So, what is a draft core implementation guide? Mr. John Carter will tell us more about the technical details about this, but let me just use simple words for now. It is basically a common foundation. It's something that is common across different use cases in the Philippines, whether it is tuberculosis or HIV or maternal care or immunization or nutrition. These are the common elements that you would find in those use cases, even as each of those use cases will have their own specific requirements. All of them will share this common foundation. You can also think of this as a minimum data set. So here we have five right now. This is the draft that we are proposing to DOH and PhilHealth, and we are going to be testing later this month. There's the patient resource, the encounter resource, the observation resource, the procedure resource, and the medication resource. Are these the only things that we need? We don't know. And that's why we do connectathons, so that in the connectathon, we can test the hypothesis that these five first resources are enough for a common foundation. So some of you are familiar with the National Health Data Repository. This is Section 31 of the UHC law. And PhilHealth is the one leading this in collaboration with DOH. On the other hand, what we are proposing today is the core implementation guide, which is led by DOH with support from PhilHealth. So just to avoid any confusion, this is how they match with each other. The core IG is use case agnostic, meaning it is the common foundation across all different use cases. On the other hand, the NHDRIG is use case specific. These were already set by PhilHealth in the many consultations that they had. They wanted the NHDRIG to address surveillance, to address the use case of referral, and to address the use case of claims. For purposes, the Core IG is foundational for all implementation guides, including the NHDRIG. On the other hand, NHDR is for national health reporting. It is stated in the law that all health and health-related data will be submitted to the National Health Data Repository for purposes of policy making and planning. In flexibility, the Core IG can grow with the ecosystem. The NHDR-IG is tailored for reporting. Therefore, if the reporting requirements change, then the NHDR-IG will change. And the Core IG, if we decide and see as a community that we need to add more resources, then that becomes now part of the Core IG through a well-governed process. So why are we starting with these five resources? Why not two? Why not seven? Why not 10? And then I'm not saying this is a perfect set of five resources. I'm just saying we should start at some point. When we talk about interoperability and core IG, we should start at some point. And for this, my reference will be the UHC cube of the World Health Organization. Here you can see a cube. A cube with at least three dimensions. The first dimension is the population, or who are the people covered by UHC. Okay. The next dimension are the services. What services are provided to this population? And the third dimension is the cost, or what is the proportion of share of a patient in the cost of care. So as you can see, if the whole box is UHC, then the blue box is where we are at right now. What does it mean? It means maybe not all of the population are still covered. Some of the population are still don't have PhilHealth membership, or they don't know that they are PhilHealth members, or are unable to access the healthcare services. In terms of services, uh, we are not yet covering all of the services. For example, appendectomy might be covered by PhilHealth, gallbladder operation might be covered by PhilHealth, but the more complex cancer chemotherapy cases might not be covered by PhilHealth. Those are services. So um, again, in this box, the blue part means we are not yet giving, we are not yet covering all the services. And then on the axis, the y-axis, we see now the cost. And the question is, are we now covering all of the costs of the patient, or do we need to do cost sharing between the system, which is PhilHealth and DOH, and the patient out of pocket? Again, ideally, the whole system, the whole payment can be covered by PhilHealth and DOH, but in reality, they are not yet covering all of the expenses. So sometimes when we go to the hospital, we still have to pay something on top of what PhilHealth was already able to cover. So if you look at the red dot, that is what we are trying to measure. And we think that if we want to measure this, then these five resources are what we want to cover. The patient resource is the population, the observation, the procedure, medication are the services, and the encounter is when the patient encounters or interacts with this medication, observation, and procedures. And that would represent the red dot. And our goal is really to fill the whole box with blue, so that now we can say all Filipinos will be covered for all services and they don't have to pay for anything, because our PhilHealth contribution was able to cover all the expenses of that patient, regardless of what that disease is. And as we all know, UHC is really more about prevention and promotion of care, because that is really much cheaper than waiting for people to get sick, getting a stroke, getting a heart attack. Those are very expensive interventions. But making sure that they have their daily um, antihypertensives, their daily hypoglycemics, then just giving them their medicines at the right time and monitoring their vital signs, that actually might be cheaper in the long run than waiting for them to suffer a stroke. So that's the reason we're starting with these five resources. So are these enough? We don't know. And the reason we're having a connectathon this June is we want to find out, are these five resources enough? Are the facilities capable of collecting this? Are the electronic medical record companies able to collect this in their system? Are they able to exchange data with each other with these five resources? We will find out in a connectathon, and we will hold this every 2 year, every 2 month, every 6 months, twice a year. So I hope that we can see some of you. Um, the space is getting limited. A lot of people are getting interested in the Connectathon. I'm sorry if you cannot join the this coming Connectathon, but definitely you can apply to join the next Connectathons. And we hope to offer more Connectathons in Luzon, Visayas, and Mindanao. Finally, an IG is a living document. No, it's not cast in stone. Um, After the policy draft is created, we hope that this can be tested in the Connectathon. In the Connectathon, we will gather feedback from the participants. This works for us. This does not work for us. Then we update the policy draft, and then we do another Connectathon, and we repeat the process all over again until we are sure that the standard is very clear, the standard is accepted by the community, such that when there is now consensus that the draft policy is ready, the Connectathon has already shown us that the tests have been passed, then we can release the policy and we can expect success. Because everyone who should comply with the policy is already well informed and well versed with how to use the standard and embed it in their electronic medical record. So I hope that this session will inform you about where we are right now, how far we still have to travel, and we'd like to invite you to join our community of practice. Back to you, JR.
Dr. Eloy, now that we've laid out the broader context of the core interoperability guide, we're very pleased to be joined today by someone who's been instrumental in its development. Let me introduce Mr. John Carter. John is a fire implementation guide developer from Cicero, Australia. He has worked extensively with government and industry stakeholders across the Asia Pacific region, helping countries develop practical and scalable interoperability guides rooted in global best practices. Over the past year, Jan has been supporting the UPMC Lab team in translating the Philippines core dataset for interoperability into a working fire guide. He brings with him deep technical expertise, a pragmatic approach to implementation, and a strong commitment to supporting country-led innovation. Today, he will guide us through the draft Philippine Core IG, explaining its contents, how it was created, and its role in the larger system of data exchange in the country. Now, without further ado, let us virtually welcome Mr. John Carter. Over to you, sir.
Thank you, JR. Listen, everybody, I will first say hello from New Zealand. We're having a big winter storm at the moment, and my internet connection is a little bit unstable. So if I have to jump off and get back on my phone, I will. So I apologize if that happens. I hope not. I'm going to spend a few minutes today to talk about the uh, uh, implementation guide that I and a couple of others in the CSIRO team have been working on over the last couple of weeks. This is a draft that's designed to get us ready for the Connectathon in a couple of weeks. And then we will build on this, and I'll show you a little roadmap of where it's going to go after this. The PH Core Implementation Guide, or IG, is a FHIR implementation guide. And if you've been through a FHIR Fundamentals course like the one that we've given a couple of times in the Philippines, or the fundamentals course now that you can get through the AHIN organization from HL7, you know that an implementation guide is the written specification of how you exchange a particular set of data using FHIR. What this does, what the core implementation guide does in a country, is localizes the base FHIR standard for your own use. And I think to explain that, let me give an example from completely outside of the healthcare world. Every big city has a problem with traffic and transit. You have some combination of cars and bikes and scooters and buses and ferries and trains and whatever. And you can talk about those things. There's a lot of things that are common in every big city that transit engineers work on to try and make traffic flow better. I know it's a problem where I live in Auckland, and I know it's a problem in Manila and every big city. And a lot of those things are universal. But if you talked about the transit situation in Manila, in any big city in the Philippines, without talking about jeepneys, that would be wrong. This is a piece of the ecosystem that is local to the Philippines and plays a special role there. It's the same thing with the FHIR standard. Most of what happens in healthcare and medicine is more or less the same around the world. You have hospitals and doctors and insurance companies and benefits, and people get sick and they get care, they get better. But there are key things that are specific to how things work in the Philippines, and specifically things about how health data works in the Philippines, and that's what we try to capture in PH Core. It's not only a technical resource, a good implementation guide also describes the best practices for FHIR-based data exchange. And as this PH Core IG grows over time, it will become more and more important as a resource for documentation and best practices, as well as for technical specs. Most importantly, again, it's a work in progress. This is really being designed with a minimal focus right now to get us to this Connectathon so that we have a common place to start, and then we'll see it build up over time. On the top of this diagram, we have the FHIR specification. There are different versions of FHIR. We're using what's called R4, and that's a stable version that's actually been in production now for a little over 5 years. There are later versions coming out. There's another version that's going to be called R6 that will come out sometime in 2026. And I predict that our PH Core implementation guide will move to R6 at some point after that. We'll probably just skip version 5. So that sits on top, and that covers about 80% of what we need to do data exchange in the Philippines. Then our PH Core comes in and fills in the other 20% with all of the things that we're working on. And then that lets us build use case specific implementation guides that inherit these kind of basic Philippines ingredients from PH Core. So we have the NHDR IG that Doc Alvin talked about just a minute ago. We have an immunization implementation guide that some of our colleagues are working on right now. And there will be many others, but they will all inherit these basic building blocks that I'll show you from our Core IG. One of the functions that any FHIR IG does, but especially these core kinds of infrastructure IGs, is to link many other standards. So we have in the Philippines, the key health data elements are described in a document, the Joint Administrative Order 2021 between DOH and PhilHealth. And this has 100 pages of details of what data should be captured and how it should be captured. And so that's kind of one of our starting points for looking at what things we need to build into the IG. We also have some international standards that we rely on to various degrees. And these include the terminologies like ICD-10, which is used throughout the Philippines to code diagnoses. There are others like SNOMED CT and LOINC that are used for specific purposes. And the Core IG will help us link all of those things and say, in this particular field or this particular situation, here are the standards that you would use from outside. Then we have a whole group of Philippine standards. The PSA produces geographic codes and educational codes and occupation classifications. Every country has similar things. They're different in New Zealand, they're different in the US, different in Australia, and so on. And you've got a set in the Philippines, and we will take advantage of those codes in our IG. And we'll do it once in the core so that all the other FHIR projects around the country don't have to reinvent this stuff. They can get it directly from the core and just inherit that into their structures. We've got drug codes that are different in every country. Every country has their own. You've got the FDA that publishes drug codes and publishes a national drug formulary. So we want to take advantage of that external resource, grab that once, and then use it in all of the medication-related use cases that will eventually have a FHIR means of exchanging data. Prescriptions, analytics, adverse events, all the things that might refer to a medication product will have a single coding system that we can look to. Another example that we have already in our PH Core is the listing of indigenous groups. So when people identify as being a member of an indigenous group, we actually have a list of codes that we can use, that everyone can use, to communicate that information once instead of all the different possible ways that it might be identified. PhilHealth produces a number of standards, and we link to those as well. So the best known would certainly be your PhilHealth ID. But we also have an identifier, for example, for people who are on the dialysis database. So a PDD registration number. That's an identifier that can be used to key against some people's care and the services they receive. We, again, define those things one time in the PH Core, and then that way, it doesn't matter what the source systems call that thing. So it might be the PhilHealth ID, it might be the PID, it might be the PIN, whatever it is in a database, in a system, as long as when they exchange data, they call it by the code that we assign in the PH Core IG. Nobody has to change their existing systems, but they all have the ability to have the data be understood to be interoperable and portable across the country. So as Doc Alvin said, you can think of this as a minimum data set or a minimum data model and guide for RESTful API interactions to record and update and search and retrieve a variety of different kinds of digital health and administrative information. We will be in our Connectathon, we'll have a couple of tracks. Now there's another webinar in this series next week, and you'll go into more detail about the contents of the tracks in that session. So today I'm just introducing the IG so that you get a sense of what's in there. And then next week, we'll go into a little bit more detail about the scenarios and the tracks that you'll be interacting with during the Connectathon. So here are the resource profiles. And you'll see that we've got the 5 that Doc Alvin mentioned and a couple of others that we snuck in for various reasons to support those. So you will be able to use these resource profiles to, again, create or search or update the different kinds of clinical activities. So we have an encounter resource profile for clinical encounters. We have medications, immunizations, observations, organizations, patients, practitioners, and procedures. And so with just these resources, now FHIR encompasses, as you know, 160 or thereabouts different resources, some of which are quite specialized, others of which are very broad purpose, like these ones. But this will give us enough that you can create a lot of good scenarios during the Connectathon. Now, next click, please. We're actually going to go into the IG and take a look at one of these resource profiles, the PH Core patient profile. Again, if you've been through a FHIR training course, or if you've been doing your own research about FHIR, you're familiar with this format, that every resource or every artifact in FHIR kind of in an IG kind of follows this same format. We've got the content where each data element is described in the table near the bottom. It's what the thing is called, what is its cardinality, and by that I mean how many times this element can appear in a data payload, the data type, a little bit of description, and so on. And we won't do it today, but you can click around in all of this to get more and more information about how you can structure your data to send back and forth using FHIR-based data exchange. Importantly, we're putting examples of all of these different things into the IG. So if you click on examples, we should have an example patient in there somewhere. There's just one example patient, and that appears in a few different formats. The narrative here is not very rich, but if you click on JSON there, you can see all the detail that goes into a patient resource, and that can serve as a kind of a template for building your own and sending them back and forth during the Connectathon. And we'll be adding over the next, so we have not quite 2 weeks, about 10 days before the Connectathon starts, we're going to be adding and enriching the resources, the documentation, and the examples so that you'll have a good set to work with on the day. And I'm going to be there as well, so I'll look forward to hopefully seeing most of you. We have identifiers and code systems. These are two different kinds of resources that we've included. So we've got identifier profiles, have our common identifiers like PhilHealth ID number. We'll probably get in a couple more, such as the other identifiers that a person might use when they present for healthcare. Maybe it's their passport number, their driver's license number, military service number, whatever it might be. So we'll get some of those in there, and those use the identifier data type. We've made some profiles for Philippine-specific things. We've also got some code systems which define terminologies, where we actually list out the codes right here in the IG for you to use when you're building resources and moving them back and forth. So an example is that list of indigenous groups that I mentioned, and we'll look at both of these on the next slide. So on the left is an example of this is the PhilHealth ID, and this is only part of the page, and I know that's really too small to read, but you'll get the idea that there's this format. For every artifact that you'll be working with, there is a page like this with a table that looks sort of like this. It has all the data elements down the left, how many times they're allowed to appear, some information about the data type and description. And that's part of a whole web of pages with more and more information. So you can click through in the IG and learn more and more about these resources, which you'll be practicing again during the Connectathon. On the right is that list of indigenous groups, and it's part of it. And so that's an example of a terminology resource that we've included directly in the IG. In a real production system, a lot of these terminology resources will actually be gotten from a separate endpoint, a terminology server. But for the Connectathon, we've included some of these resources right in the IG, which will make it sort of one-stop shopping and a little bit easier to build those first examples. So you'll see a number of these different kinds of resources as you start looking around in the IG. Data type profiles for identifiers and the actual code systems with the individual values that will go into some of the elements in our profiles. All right, so where are we and where are we going? This IG, as we've said, is quite contained. It doesn't have anywhere near everything that you would need to go into full production. But between now and the Connectathon, we are going to be adding a little bit more to it. We'll be adding the immunization resource, which is not in there. We'll be using that at another event later in the week. We'll be tightening up the profiles, adding a little bit more documentation, that sort of thing. And then we will be loading the IG contents into the endpoint servers so that you can make RESTful API calls using Postman or other tools to practice and test out all these things at the Connectathon. What we hope will happen on those 2 days is you'll try to create something, you'll try to create a patient resource, and you'll take what you know to be good data, you know this is a real scenario or a realistic scenario, and you'll try to create it, and something in the IG will prevent you. Maybe we have not included a field that you need, or we've only included a field as occurring one time, but you know in real life it occurs 2 or 3 times. We'll take all of that feedback and bring that back into the IG right after Connectathon is over, so that then it will just work better. It will actually be closer to real life. Longer term, after that initial round of feedback, the process just continues. I was looking at an Australian example, the Australian Base Implementation Guide, which serves a very similar function. They've been working on it continuously since 2018, and it's by no means complete. So this is not a thing that you do in a month. This is a thing that actually continues with at least some maintenance going on, probably for several years, while FHIR adoption is brought to more and more parts of the health ecosystem. We'll find more and more things that can be best done in an abstract or a semi-abstract thing like the Core IG. Importantly, we'll also start to talk about conformance criteria. So the IG will say for a service, let's say an EMR service, to be presenting high enough quality information, here's what that means in detail. For if it's information out of patient, there are certain fields you must support. And there are certain things that you must be able to handle if someone sends you a patient record that you don't want to lose because they're important. Well, so that will come into the IG. And then a formal governance model. Who actually owns this thing? I'm working on it now under the auspices of CLAB, but there's still a discussion underway about the right interaction between PhilHealth, CLAB, DOH, and many other stakeholders who all have a role to play in this. So that governance model will become very important. And then most of all, as Doc Alvin said, as everyone has learned that does this kind of standards work, it takes a community of people to do it. It is lonely if you're just doing it by yourself. Jorn Guy from CSIRO and I have been working on this IG over the last couple of weeks, and it's just been really the two of us as we get ready for Connectathon. But obviously, in a country that is the size and diversity of the Philippines, this to be a truly national resource, this is going to require hundreds of contributors from many different organizations, public and private, in order to really be the thing that it needs to be. And so you'll see that governance and community being the most important parts. The technical parts eventually will start to just happen because there will be enough experts who will know how to do that part, and it will stop being a technical exercise and it will become more of a governance exercise. And that will be the point when there's real success. So I'm really looking forward to working on this with you over the next few weeks and seeing you in Manila in a couple of weeks. That's the end of the slides. And I think that our next item on the agenda is to have a little bit of talk and questions and answers about that. And that Doc Alvin is going to lead us in that fireside chat. So Doc, over to you.
So thank you, John. If anyone in the audience has a question, please feel free to type it in the chat box. And while we're waiting for you, maybe I can ask John. John, what's happening in other countries, by the way? How do they develop their own core implementation guides? Over.
Yeah, look, it's a great question. There are a number of different models, ranging from some of the European countries, which are relatively small, have a core often out of the government, out of the Ministry or Department of Health, who kind of work on that. Usually the HL7 community is involved as a stakeholder, sometimes as the publisher. So you see that in sort of small countries. Australia has a very wide community that they've actually got funding from their government to go out and and build a community. So now there are hundreds of people who are actively involved through something called the Sparked Accelerator that has been working on building their Australian base and core IGs, as well as some others. And so that they've actually been able to hire a professional staff to facilitate groups to work on this. Maybe a role similar to how CLAB acts as facilitator for the community of practice. The US has historically had a very industry-led group, so the software vendors have tended to take a really central role in developing the standards in the US. They say, look, we're building these big electronic medical records systems, and these are the data structures that we need. We agree amongst ourselves as kind of software vendor competitors, so let's make this the standard, and that's sort of led things. But then more recently, the government, with something that used to be called the ONC and is now called the ASTE, a federal government department in the US, is playing a good role. And so there's a good balance between government and private there. So the answer is almost every country has a slightly different model. Some are more government-led, some are more private sector-led. But the key commonalities are the successful efforts have more stakeholders. So you get government, you get academia, you get software vendors, you get patients, and so on, all in the room. And the more people you get in the room, the more successful these efforts have tended to be. Over.
Thank you, John. I think the key message is a standard by itself is not enough. There needs to be a community of adopters of the standard. Uh, because if the community does not even know how to use the standard, then the standard just becomes an online resource that no one can actually implement or adopt. So we have a good question from Les Matayan, but Les is one of our participants in the last FHIR fundamentals training, John. He's from Baguio General Hospital, and his question is, are we allowed to fork or clone the PH Core GitHub repository? Over.
Yes, there's no reason why not at this point. The only thing I would say is that what we have up there right now is very much in a state of active construction and flux. It probably, a disclaimer, it doesn't represent the views of PhilHealth or the Department of Health or any sort of official body. It's a thing that we're really preparing at the moment just to make sure we have something good for Connectathon. So I might say, sure, go ahead, it's out there, but it will be better in a few weeks. It will be a thing that will be more stable and more meaningful in the few weeks after the Connectathon.
Thank you, John. So, John, I mean, you've been helping us for the past year and a half. The Philippines originally took a big bang approach. We had the use cases for the NHDR, for surveillance, for referral, and for claims. And that's why the NHDR implementation guide was quite a long list of data elements. Why is starting small a better approach? Why would you think that starting small can be more strategic over John?
I think the reason, there's two reasons. One is that expertise with FHIR is something that takes some time. It's possible to learn the technical aspects of FHIR at one pace fairly quickly. You go through the course, you read the documentation, and if you're a smart engineer, you understand it. But actually using it is a different story. And I think that as the people who work on the guide are learning, they are doing things differently than they did at the beginning. So a small approach makes it easier to go back and change those things and then take advantage of the learnings going forward. A big bang approach means that you work very hard, like waterfall software development. You work very hard on something and you don't test it until it's all done. And then you find out you've got this big thing that doesn't work. So starting small allows you to test and grow and change and find the right style as FHIR itself is changing, as your experience is changing, and as your use cases are evolving all at the same time. I think that's the most important reason to kind of grow as we go.
Mhm. So it's like managing the complexity, John. Uh, if if we all want to run the 100 meters, it all starts with that first jump of, let's say, 1 meter. And that first jump, we want to make sure that everyone in the community, all the implementers, all the hospitals can actually make that first jump. Or else, if they cannot even make that first jump, how can we expect them to go the 100 meters? So by cutting it up into a PH core, we're actually making sure that it's bite-sized, it's accessible to as many people as possible, as many implementers as possible. It doesn't mean that we will not go the 100 meters. It means we will get at that point. We will get to all of those use cases. We will come up with much more than surveillance, referral, and claims. I'm sure we will have tuberculosis. We will have HIV. We're already working on immunization. But it becomes a systematic approach of expansion and a governed one where the community is part of the process and they give feedback. They give feedback. We already know all of the past experiences of the Philippines where a policy will be released. And the policy has a major impact to the electronic systems of the hospitals and the healthcare facilities. And it takes them time to adjust to this new policy, sometimes more than 6 months, sometimes 1 year. And we've also seen PhilHealth and DOH extend deadlines because the community needed more time to adapt to the policy. That's still the same sequence. DOH will still publish and then the facilities will still follow. But what we're trying to do is do a prequel, so to speak. Let's go before releasing the policy. Let's test the policy so that the implementers are able to get their hands and understand the draft policy and prepare themselves to comply and adjust to the new policies, make revisions and updates in their software, do the proper testing. I think from the cybersecurity perspective, that is also much, much better. They're not rushed. There's no deadline. They don't take shortcuts. And we can do a proper cybersecurity testing after a connectathon. If everyone passes a connectathon, then we can also do a cybersecurity test. And then when everybody passes the connectathon and the cybersecurity test, then we can do release of the policy. And then it will be a much more peaceful world, so to speak, because now the implementers are well prepared to adapt the new things. Um, so there's a question. How can we ensure that future changes, fragmentation, or agency-specific deviations are minimized to maintain interoperability? Would securing commitment and technical champions from both DOH and PhilHealth help institutionalize the PH-FHIR core and ensure consistency across programs and platforms? So if you remember, as I said, Silab is about the 5 Ts. We do teaming, which is what we're doing here right now. We're coming together as a team to talk about what we need to do. We do tooling. So based on what we agree as a team and the understanding of the draft policy, we come up with the PH core. It's just one of the tools that we have. Then we do training. So you can call this part training. We're doing an orientation on what core implementation guides are all about, how it relates to the NHDR IG. So we're learning, there's knowledge. Then we do ability testing. That's why we have connectathons. We test whether the knowledge that we have are enough to address the needs of the policy. And then we do transfer. So essentially, we transfer this all to DOH and PhilHealth because in the end, they're the only ones that are mandated to publish the national standard. So yes, Undersecretary of DOH and Chief Information Officer Emelisa Perez Chong is fully aware of this process and she's expecting the output from the community. She's expecting us to give a report back to her on how the community fared with the testing in the Connectathon. I think that will be very useful for her to make a decision when the standard is ready to be published. She will be there to grace our occasion on June 16. So that answers the question of Dr. Paulo Bacchiano and JL. Is there a formal process for validating that the PH Fire Core aligns with the reporting requirements of DOH and PhilHealth system? So right now, no. But since you've asked that question, then we have to start doing it. So essentially, the PH core, and we have a Mentimeter later on, JL. So you might want to put that in. Like alignment of PH core with data reporting. That might be a one use case of why we need to have a PH core to make sure that all of the reports reaching DOH and PhilHealth are actually conformant with each other. So we don't need to submit once to DOH and another one to PhilHealth, because it's the same data set anyway. So we can just send it to one, the National Health Data Repository. Everyone agrees that's the standard format, and then DOH and PhilHealth will just extract from the NHDR and perform their analysis. Um, any more questions? John, is what does success look like for a core IG, maybe for the next 6 to 12 months?
I think success looks like we start to see other IGs coming out that refer to the work that we do in the PH Core IG. So we hope, for example, a fairly small example. We've made profiles on how you represent an address, a physical or postal address in the Philippines. So we now have extended the base FHIR standard so that you can write an address the way you write it in the Philippines. There are codes for barangay, which there are not in Australia. They don't have barangay in Australia. So we've got that in our PH core. And what we hope is that and you need an address for everything, right? Patients, providers, healthcare facilities, everything has an address. So if we start to see people using the work that we've done in PH Core, then we'll know that we've saved them some time. They didn't have to reinvent how to write an address. They can just look at ours. So I think that's going to be the key, is when we actually see people adopting some of the work that we're doing.
Thank you, John. I know you had a slide about core IG versus the NHDR IG, and I use versus, but they're not actually competing. They're just one is just part of the other. So maybe you can just very quickly just uh, inform us again the difference between core and NHDR IG.
Yeah, absolutely. The NHDR team looked around when they first started their work and said, we need to do all of this because it wasn't there yet. And so they made a lot of the same things, a lot of these same artifacts, a patient and encounter, and some of these basic building blocks that they needed to build for what they saw as the first time so that they could meet the requirements that they had for NHDR reporting. And they used the name of calling this a core, or a core data for interoperability. At the same time, they were working on some very specific use cases. How do I model the PhilHealth Claim Form 1? How do I model the PhilHealth Claim Form 2? And so on. And sometimes those two things got sort of mixed up. So there is, in the NHDR IG, there are some very use case specific models and some very general models all at once. What we're doing is we're separating out the very generic kinds of Philippines-wide models and putting them in this new thing that we're calling core, so that the use case specific things needed for PhilHealth claiming and the other use cases, surveillance and so on, will be in separate IGs. So really what we're doing is we're just teasing out the stuff that's common and generic and calling that core, and then leaving the things that are more use case specific in different IGs that refer.
Thank you, John. So we have about 10 minutes left. So let's go to our Mentimeter. I'll pass the floor back to JR. But if you still have questions, please continue typing it on the chat box. JR?
Doc. Thank you, John. Now, I'd like to invite the participants to share their thoughts. May I request the participants to please quickly scan the QR code flash on your screen, or go to www.menti.com and enter the code provided on your screen. Our code is 783-44845. Again, 7834-4845. This is our questions to our participants. What real-world healthcare workflow would you like to test at the Connectathon? Okay, we have referral and appointment scheduling, FHSIS, TB, e-consulta, child immunization and AEFI surveillance, e-consulta, referral and reporting, referral and appointment scheduling, FHSIS, check immunization status, missed vaccination and automate reminders. We have a lot. NCDs, referrals and reporting, monitor missed TB dots, check up, and automate reminder and inform TB dots manager and supervisor, laboratory results exchange, supply, and pharma. Doc Alvin, John, do you want to comment regarding their answers?
John?
Fantastic. We won't be able to solve all of those things in 2 weeks, but we will
Yes.
have some basic building blocks that are needed by, I think, all of those different scenarios. So that really gives us a good roadmap for the next 5 years.
Right. So I think, for example, can you bring that back? Um, in a referral system, there's a patient, there is an encounter with a practitioner, an organization, and a facility. And then there's a reason for the referral. It might be an observation, a condition, a medication, or a procedure. So I think we got that covered. But we will know in the connectathon whether a referral use case can be satisfactorily covered by the draft PH core. So that's the point. The point is if we say yes, these five resources are sufficient for a referral, then we're good. If it's not sufficient, then we will smoke out, so to speak, what are the missing resources that we should be adding to the core IG. So as you can see, this is not just a small group of people starting to think about what resources do we need in a core IG. It's really the community, the people who are on the ground, the people who are face to face with the patients, already seeing the challenges of referrals, back referrals, the challenge of directly accessing the hospitals without passing through the rural health unit. So those experiences are what we want to get in the connectathon so that you can really inform what the final PH score will be. As you all know, this is just draft. So in the end, the draft is nothing. It's not really the official thing yet, no, but it really helps us understand what is workable for a specific use case. And if it's lacking a specific resource, then it's time to document it properly. It will be in the GitHub. It will be in the minutes of the Connectathon. And then we feed it back to DOH and PhilHealth so that they know what's the situation also on the ground. Because a standard is like a bridge. At one end of the standard is government, and on the other end of the standard are the implementers, the people in the healthcare provider networks who are face to face with the patient. So, and both sides need to have a common understanding of what needs to be done, what needs to be submitted in terms of data. Uh, so I think the AI of Mentimeter summarized it. No, we have. I think I like the previous view. This is groupings already. So there's referral grouping, there's FHSIS grouping, consulta, reminders, surveillance. I think these are very important inputs. No, so I think what we will do is we will keep documentation of this, make sure that they are clustered accordingly in their common categories, and then we will schedule our connectathons around specific use cases. And that's part of the community consultation process. we'd like to find out from you what are your most pain points, so to speak, so that we target the pain points ASAP. Now, what's important also with the Core IG is the reusability of these resources. So if you already have the resource of patient name, patient address, then you don't need to repeat that anymore in the use cases. All you need to do in the use case of TB is just point to the Core IG when it comes to storing the name and address of the patient. Same with HIV, same with immunization. So by reusing the Core IG, we can focus more on the specific requirements of the use cases and makes it more efficient. And we have that commonality already across all use cases, making it a very powerful Core IG. Maybe final words from John?
Um, I think that I'll put one more plug in for what we hope to get out of the Connectathon, and that's if people come to us with any coded data elements that they use in their local system. I'm really eager for us to start collecting information about what coded data is flowing around so that we can start to capture that aspect, because that's a really important part of a core, is to identify those common code sets that people use to record any coded data elements. So we'll be thinking about not only more resources, but also the codes for anything that's coded that people use to start fleshing out the IG that way. And that'll really be something useful, I think, for the whole country. But I'm really looking forward to seeing everyone in a couple of weeks. So I hope you all are able to come to the Connectathon.
Thank you, John. And with that, JR, back to you.
Once again, we invite you to join our second pre-Connectathon webinar, Introduction to the June Connectathon and How to Use the FHIR Implementation Guide on June 11 next week, 9 to 10 a.m. with Dr. Michael Lolly as our speaker. And of course, to our main event, June 2025 FHIR Connectathon, happening on June 16 to 17, 2025 at Hilton Manila, Pasay Cities. See you there. Now, for us to improve our next session, kindly answer the evaluation form flash on your screen on or before 12 noon today. And on your right, you may scan the QR code to join our community of practice. Okay? Thank you all for actively participating. Let's continue to connect, collaborate, and learn together. This is Jer Pingo saying again, catalyzing change one spark at a time. Let's keep pushing the boundaries of digital health together. See you. Bye.